nano. What is big deal about nano? Okay, and nano, it can go anywhere from pure physical sciences to pure biological sciences, or everywhere. So the first question is why nano? Okay, and I've just given one simple example. A nano is an unifying concept for all biological systems, okay, including everything from genes that carry messages for life and living to proteins and macromolecules that make and run over our lives. So that's what nano is, because nano covers everything. Okay, failures and impediments in medical interventions, including drug delivery, surgery, genes and cell replacement therapy, and life-sustaining devices, okay, can be traced to our lack of understanding of nanoscale biological structures and functions. And I'll give you just one example. Let's suppose somebody has Alzheimer's disease. Okay, none of us will have here, and hopefully none of us will live long enough to be even worried about. And I don't think that Indians have predisposition for Alzheimer's disease, but nevertheless, everybody is worried about that. So we all know that we are multi-scale living system. Okay, because we are from meter ourselves, we are meter in length, or it might be in feet, or if you are in US it's a feet, here you are in meter. Okay, but nevertheless you are meter. So if you have Alzheimer's disease, all you are interested in that you have two things. One is there is a memory loss, and two, there is some defects in the brain, which is plaques made of amyloid beta protein. Okay, so if you look into here, this is literally you are going from meter to millimeter range, because the plaques are not more than few millimeters. If you do pathological testing from biopsy, it will be few millimeters in size, but you're already going from meter to millimeter. But that's not the end of it, because each plaque, they are made of amyloid beta protein or tau protein, and they are in micrometer range. So you're going already. So this is actually atomic force microscopy image of the fibers which form the plaques. And these fibers are anywhere from 30 nanometer to say 100 micrometer. But you're going in from meter to micrometer, and this doesn't end there, because what happens now is that we know in last 5 years or so that almost every amyloid disease, which includes diabetes, tuberculosis, systemic amyloidosis from heart disease to Alzheimer, Parkinson, Huntington, all of them are not because of the plaques having fibers, but because they are small oligomers of these proteins. And so these proteins, as I'll show you later on, they form ion channels, and these ion channels are truly nanoscale structures, because their size, the diameter will be say 5 to 10 nanometer with a pore of 1 to 2 nanometers through which calcium ion, sodium ion, potassium ion, all of them can go through. Okay. And they are in the membrane. All the cell membranes are not more than 5 to 6 nanometer in thickness, with the protein extruding in and out. At best it can go up to 15-20 nanometers. So in a real sense, all the ion channels and receptors in any membranes are all truly nanostructures from every directions. In fact, even from functional studies, the opening and closing of ion channels or binding of, say, a drug to a receptor, they're all in nanoscale features. So they are truly nanostructures. In fact, we can say that almost all body functions and diseases relate to nanoscale structures and their activities. So that's where the question now is that if we don't understand the nanostructures, we'll never be able to diagnose properly, and we'll never be able to treat properly. Okay. So those are things that you have to keep in mind. So the question now is, what is the nanomedicine? And that's the third part of my talk, is that nanoscience and technology and nanomedicine. I'll come to each one of them. So what is nanomedicine? Nanomedicine is about, I don't know if you have enough light or not. This is modified from the NIH definition of nanomedicine. So nanomedicine is about diagnosis, treatment, and prevention using science and technology at the scale of molecules and structures that make and run human cells and tissues, as I showed in previous slide. So what it means is that every nanoscale structure that we have in our body are pretty much that's define what we are and how we live, okay, and how long we live, how we survive. Okay. So broadly defined in nanomedicine, we can we can split it in three parts: diagnostics, therapeutics, and devices. Now in diagnostics part, you can again split in three areas. One is defining targets. For example, if you are designing some drug molecule or some therapeutics, you have to know the receptors. And most of the time, almost 95% of times, you have the drugs, we don't even know the structure of receptors. And the conformation of a receptor becomes very critical if the drug is binding in the proper way or not. If they don't bind it, it's basically enzyme, reactions. It's a very defined structure, interactions. If the conformation is not right, you may not have any effect, or you might have side effect. Okay. So defining targets becomes a critical part of diagnostics. Okay. Defining the cause and diagnosis of pathology, that part is there. Third part is that even if you have a drug, and you want to see whether the drug works effectively or not, you want to monitor them at nano scale, because remember, ultimately they are binding to receptors and channel. They are nano structure. So what means is that if you do bulk assay, if you go to doctor nowadays, all bulk analysis, and I'll show you later on that doesn't work most of the time. Okay. Now if you go to therapeutics, you can design the therapeutics, you can do the drugs and interventions, and conventionally you are using pharmacological assay, which is a bulk assay, or you are doing so-called combinatorial chemistry-based drug design. Okay. So designing therapeutics is where nano will comes into play. You can do targeted delivery, because that's the most advanced or most promising area of nano medicine, the delivery of therapeutics, drugs, and in small molecules. And the point is very critical. Like suppose if you take that in cancer, for example, most of the people die because of side effects. They don't die of cancer itself, because the treatment that you have with radiation or chemo is very broad based. It doesn't have, it's not focused, it's not targeted. Instead, so suppose somebody has pancreatic cancer, you can take the drug, it goes everywhere in the body, and it will affect the cancerous cell, non-cancerous cell in the pancreas and everywhere else. So if you cannot target the drug, what it means is that one, is going everywhere, and two, the dose that you are giving is very high. So literally 90% or often 95% of drugs that you are using is completely wastage, or it will have side effects. So the targeted delivery becomes very critical. Then basically you want to, this is basically linked to it, that you want to optimize the efficacy and minimize the side effects. And that's where the nanomedicine has the promises also. Okay? And then the nano devices are devices to maintain tissue activities. For example, suppose you have somebody has Lou Gehrig disease where they can't, have it, their throat doesn't work. It's basically they can't breathe. Now, if you have nanomotors that is put in all over in the trachea, and you can remotely control the motor activity, you can keep at least the trachea moving. Or for example, if you have a brain-machine interface and your vision is lost, you can literally bypass the visual signal by having a chip that will transmit the electrical signal from in here, and you can see it. So those are the devices that are all based on nanotechnology. Okay, so now where does nano started? And that's a question, it's a fair question everybody can ask. In fact, you can trace back to the nanoscience and technology with the two major discoveries. One was nanotube, okay, that shows you that yes, there are molecules and there are structures. It has completely different functions, and it can perform many wonders. Okay. Second one was the development of imaging technique, scanning tunneling microscopy and atomic force microscopy. And those two things were very critical, because if you really want to see any, say for example, biological receptors, say the receptor for acetylcholine receptor, which is involved in your neuromuscular contraction, Those receptors, if you want to look into real time whether the receptor works in the presence of some drug or not, you cannot do it, because electron microscopy is the only way you can do it. And electron microscopy, as you know, every physicist will know that to have the electron very high energy, it has to have very large mean free path. And that's classical example is a old TV set. It has an ultra vacuum where the electron has to transfer. So larger the vacuum means larger the energy of electron means larger the vacuum, and higher the vacuum range of vacuum, the water is not there. So what you're seeing is in electron microscopy is a dead tissue. It's just a snapshot of a structure, nothing dynamics. So a scanning tunneling microscopy and atomic force microscopy open the field to look at the structure in living condition. And this is what it said, this is adventure in Lilliput. This was in 1991, but at that time itself, it was promises of nanoscience was, it was apparent. Okay, and what is interesting part is that if you look at here, say that using powerful new tools, biologists at the University of Chicago have gently sliced through a red blood cell to peer at individual protein molecules, clinging to the inner membrane. So what these biologists were doing, in fact, they were not a biologist, they were physicists like us. What we're looking at is that how these red blood cells are involved in sickle cell anemia, because the cytoskeleton is very different there. And so in interest for us was that can we look at a red blood cell and look at the mechanics and the structure at nano scale. The other end was that since in heart, for example, if you have a heart problem, you have cardiac arrhythmia, tachycardia, heart beats very fast or beats very slow. What happens is that cells in hearts do not communicate directly, and very fast. So what means is that the heart does not work properly. So it doesn't have enough energy to pump the blood everywhere in the body. Okay, so that's the arrhythmia is because lack of cell-cell communication. So we wanted to look at, or nobody till that time was able to look at the structure of the channels which connect two cells in between. You can look at the other side by doing electron microscopy, but not lot. So what they were done is that, basically this was the structural model, and looking at the structure at this level here was almost impossible. So using atomic force microscopy, these people were able to dissect it, the membrane. Again, this is the dissection of nanoscalar structure. Okay, so the term nanodissection was the first time defined in 1991, which is nanosurgery in a sense. So a lot of people want to do nanosurgery, and in fact, if you have resources and if you have good students and postdocs, in 5 years' time, you should be able to design system where you can do very localized nanosurgery. So the science is there. Okay, technology is not there, efficiently, and application is limited. Okay, so this is the structure of the the ion channel here, which was used after dissection. So this is the part of the thing is that nano was already there, and it started because of two things. One, the invention of imaging modality, for which Binning and Rohr got Nobel Prize, and STM and AFM was developed a little bit later, and actually we were the first one to use it for biological application. That's the only name and fame that we have. We didn't develop atomic force microscope. The other part was nanotube, for which also Kroto and I think one more, Kroto and Smalley got Nobel Prize, and those are two Nobel Prize winning field, area that open the field of nano science and technology. Application to medicine is what we got into. Okay, so first I'm going to talk about designing nanotechnology for biomedical application. It will be very brief. I'm not going to go into detail, and all the application, all the technology development that I'm going to show you here is entirely based on atomic force microscope. Okay, and there are many parallel technological development that I cannot cover, but we do work on many of them. Okay, so what we are trying to do is that we are going to designing integrated atomic force microscope for nanoscale functional and structural assay. Okay, because our aim is to, if you want to do real nanomedicine, we want to see nanostructures in dynamic state. And to do that, just looking at nanostructure in dynamic state means I'm not only looking at the structure, I'm looking at its activity, and also I'm looking at its, its response. Okay, so I'm combining atomic force microscope with fluorescence microscopy, single molecular, optical tweezers, patch clamp, permeability assay. Some of them will, you don't need to, remember. You can just do the Google search and you'll know what I mean. Because I'm not going to go in detail here. And this is just a cartoon. So this is atomic force microscope cartoon. And since I'm not going to define that's a different full seminar by itself, I just simply tell you that atomic force microscope is like a molecular record player. So if you, I think many of us of our generation, at least we know what record player is. Younger generation perhaps may not. So in record player, what you have is a very sharp needle, and raster scan on the record. And as it raster scans, every point it gets in the groove and creates a mechanical vibration. And that mechanical vibration is transmitted to amplifiers through electrical signal and converted to, sound. Okay. In atomic force microscope is the same thing. What you have is that instead of a sharp needle, you're supposed to have atomically sharp needle, which normally is not the case, and it raster scans on the surface. Now, if the physics comes here, very simple, that if you take the Newton's third law, or any law, if, as long as there are two bodies, there is always a force of interaction. The strength of interaction depends on how far two bodies are. If you are very close, interaction force is very strong. If you are very far away, interaction force will be very weak. And the nature, whether it's attractive or repulsive, depends on the nature of the molecules there. If you say, for example, you say both hydrophobic molecules, they will repel. If you say, if you are electrically charged, positive and negative, that will act differently than both positive charges. Okay. So nature and force are, that's where the atomic force comes into play. So what you are looking at is that if you are bringing the AFM tip at a very sharp point here, as it comes close to here, there is a force-force interaction. And depending upon nature, it could be repulsive or attractive. So all you want to do is that measure the force of interaction. Okay. And that is done by various ways. The most common one is that you have a cantilever, and cantilever by definition is anything where one end is fixed, another end is free to move. Okay, and so you can measure the spring constant of the cantilever. Okay, and believe it or not, if you just take one small aluminum foil and very thin aluminum foil, 1 meter, say 1 millimeter aluminum, actually 5 millimeter aluminum foil, and you just hold it one hand and just touch it on this side, the mechanical force vibration that it has, the spring constant, is almost as good as mechanical force of interaction force of two atoms interaction. Okay. So what it means is that you do have a system where the cantilever is sensitive enough to measure the force of interaction. So what it means is that if you have a specimen here and it's a repulsive force, then this cantilever will just repel. Okay. And it's sensitive enough that it will repel. It's sensitive enough that you can repel up to interaction force of 1/10, with the force of a spring constant of 1/10 of interatomic vibration. Okay. So then you can, what you are doing is that just like record player, you are just literally mapping the mapping the deflection of the cantilever, and then you are feeding back. And since you are going into XY direction anyway, so you have truly X, Y, and Z coordinates at each point. So unlike electron microscope or other light microscope where you have electromagnetic wave, there is no electromagnetic wave here. So what it means is that since there is no electromagnetic wave, your resolution is not limited by diffraction and spherical aberration. And that's where you cannot see anything with light microscope, because light microscope at best you can see is half the wavelength of light, which is broadly speaking 200 micrometer, 200 micron, 200 nanometer, not 200 micron, half a micron, on 1/4 of them. So wavelength is half a micron, so means half of wavelength means about 200 nanometer at best you can see with any electromagnetic wave, unless you go to electron microscope where you can see the single atoms, but again it's nothing is living. Okay. So that's the atomic force microscope here. Okay. And now, since remember this is atomic force, since a force, and in physics all energies are transferable or convertible. So it means that you can measure the force of a hydrostatic force, or you can measure electrostatic force interaction, or you can measure magnetic force interaction, and you can convert all of them. So that opens the whole field of looking at the physico-chemical properties of materials. Now, since there is no electron, no vacuum here, what it means is that this is a very simple system that can combine with any other modality that you want, depending upon what expertise you have. So in this case, for example, we have nano chips with a pore in it, and we have turf, we have fret, and SPR. All of them are combined in one system. And this is light microscope coming from bottom, so it can be confocal, it can be multi-photon microscopy, or it can be two-photon microscopy. All of them you can combine. Okay. And because our aim, for example, is that to look at the opening and closing of ion channels that controls the cellular behavior. So I can put a membrane on top, and there is a pore here, and we have nanofluidic chambers. I can put a very small amount of drug molecule or antibodies, for example, and I can look at whether channel open or closed. So this is all the technology that we are developing. Okay, and we are combining that with optical traps and so and so. I'm not going to go into detail, and this is just to show that yes, you can make nanotube AFM tips that basically on 1 to 2 nanometers sharp. So means that if you are a structure which is 1 nanometer or half a nanometer, you should be able to map the force of interaction with these AFM tips. Okay, and this is just to show the example of multimodal imaging, that you can do fluorescence microscopy and AFM together, you can do confocal microscopy and AFM together, you can do electrical recording and AFM together. You can do, you can make a nanopore chips, and and if you're looking at high throughput screening of drug molecules, you can make array of nanopore chips, and you can see whether the ion channels are open and closed in response to particular drug molecule, candidate molecule or so. Okay. You can do permeability assay, looking at single movement of single molecule in and out of channels. In fact, there are not many systems available that will allow you to do that. You can extend that one to looking at the fluidics lab behavior. In fact, this is just to show a cartoon that is going to show, but I'm going to show you next slide. So you can do nanofluidic sensors, and and this is the idea that we have is that we are trying to make the sensor that will sense even a single photon movement. Okay, and again, I told you that the sensitivity of cantilever is good enough that even a flow of single photons here will be able to change and deflect the cantilever. Will be able to measure it. But that's the promises. That's not available right now, because that's a 2 PhD students, good students can do it, and it's very difficult to do it. But again, the point is that we are designing nanofluidic sensors, or you can do it. We can do the nanoscale velocity, viscosity and velocity measurement with AFM. If you are a physics student or chemistry students, you know what a Stokes law is. Okay, and Stokes law is basically defining the relationship of viscosity, velocity in a fluid in the presence of some molecules. Okay, you can define that one. So this is the equation there. But if you look at a nanoscale, there is nothing available before we did the work. Okay, and the question is the Stokes law valid at nanoscale? And the answer is yes. That the Stokes viscosity law is valid. Keep in mind that there is no viscosity law at nanoscale, but what we have shown is that that's still true. And this is very important. You say, why am I doing it? I'm doing a nanomedicine. Why physics part here? The point is very simple. Like suppose you have atherosclerosis, or you have a blockage in your artery, because and what happens there is that the blood flow locally is changed. So shear stress on the cells lining the blood flow in blood vessels, it has a local shear stress and local viscosity change, and that translates into the ion channel. Most likely potassium channel is involved in the controlling the contraction or expansion of the blood vessels. This is all at nanoscale. So you like to know what happens at nanoscale with the viscosity and velocity, and that's what comes into play. On the other hand, you can also use these nanofluidic sensors for high throughput screening, and I'll come to that one later. Okay, so for example, the sensitivity of this one is so good that if you have, say, 5 millimolar calcium chloride, and you have 1 millimolar calcium chloride, you will be able to measure the change in viscosity and ionic concentration in this nanofluidic chamber, all with simply looking at the mechanical force that it creates based on the molecular structures or molecular nature of the fluid. Okay, so this is designing the nanosensors for both structure and function. Okay, so you can image the topography and 3D conformation by AF imaging. You can look at the interfacial energy of intermolecular interaction, and that is something very interesting because at interface, at nanoscale, everything is different. And because say all the atoms and everything, all the electrons are free to move at the surface. They're only held by a specific nuclear forces. But they are free to move. So the surface becomes a quite open field, and almost many physicists and material scientists are still working on to figure out what the surface properties of materials. Okay, so what we did is that we looked at the surface energetics of single atomic steps in graphite. Okay, and what you see here, for example, this is atomic force microscopy image. And every time you see the high, bright or color means higher from the surface. So in this case, this is one atomic step. In fact, it's only 2.3 angstrom or 3 angstrom, something like that. That's the atomic step of a graphite. So this should not be any structure on top here because I'm just imaging on this side. But you see here there is a structure here, feature there. What it is basically energy profile at the interface. This was the first, evidence of structural evidence of energy profile at the atomic steps. You say again, you ask question, why am I doing this when I'm looking at the biology? And I'll show you later on that simple reason is very simple. Like if you're looking at ion channel opening and closing, the surface energetics there, is truly at this level. So using this information, I can predict whether the ion channel is made of hydrophobic amino acids or hydrophilic amino acids and so, because that will tell me what kind of drug I can design to control its behavior. Okay, so that's the topography. So now I'm going to go for applications. So first I'm going to look for defining targets, diagnostics, and therapeutics using the thing that I defined: and imaging, sensing, energetics, and nanoscale transport measurements. Okay, and the disease targets that we use in our lab, in our group, are so-called protein misfolding diseases. There are 30 of them. Including Alzheimer disease, Lou Gehrig disease, diabetes, cardiovascular disease. We work on cancer and we work on muscle and bone damage, and we'll come back to one or other, as I go along. Okay. So as I mentioned, the gap junction part, that was the Time magazine image that you saw. And gap junction, hemichannel, and cell-cell communications are the critical part. In fact, if we didn't have gap junction, none of us will be here, because maintaining the metabolic homeostasis of a tissue is because of the presence of cell-cell communication channel. And the word gap junction was given by my postdoctoral advisor, John Paul, a long time ago. And what we have shown is that the gap junction is not the most basic structure for cell-cell communication. In fact, it's the hemichannel is the most basic structural component. That all came through atomic force microscopy imaging of looking at the structures. I'm coming to that part, which is, so this is a key structure for evolution and sustenance of multicellular organism. Okay, normal physiological roles are maintenance of metabolic homeostasis, control of intracellular space, synchronized electrical wave propagation, tissue growth, and survival. So if you look at the structure, if you take the two cells, put up some fluorescence marker here, they are connected, so the fluorescence will go to this side, and they are all connected. Now you can think about it that if you label antibodies to this gap junction channel, you should only see those gap junction channels where the cells are connected, but you can see everywhere it's there. So this is already a hint from fluorescence imaging that, well, gap junction is not just in one place, it's in many places. So but there is no cell, so it has hemijunctions. That's the hemichannel. Okay, so this is a model that is defined from electron microscopy, that there are two hemichannels aligned end to end, and the molecules up to 1,000 Daltons can go from cell 1 to cell 2 and vice versa. So that's why they maintain the homeostasis of the cellular tissue homeostasis. Okay, so what we do is that we look at individual cells and see what are the hemichannels. Okay, and that so that is shown in next slide here. So this is actually the open and closed hemichannels. So what we did is that we took the hemichannels from here, isolated from cell membrane, reconstituted an artificial bilayer, which is truly 5 nanometer thick structure, and we looked at individual hemichannel in both closed state and with open state. That you cannot do with any other technique at this high resolution, including X-ray diffraction, NMR, PET, anything you think about it, you cannot do in real time. Everyone has limitation. So what we looked at that is it's a closed state of one of these channels, and this is open state. And this open state is due to loading of calcium or oxidative stress. Oxidative stress in this case that we worked on is smoking. So what we did is that we took the real cigarette, put in the media where these membranes with ion channels are sitting there, and I'm looking at what it does to open and close state. And and then we correlate that one with the behavior on the cells. And the active, cells from lung, human lung, and we looked at how does it work. So what we found is that when you have the oxidative stress, that oxidative stress depolarizes the membrane. Once it depolarizes the membrane, it just opens these ion channels, hemichannels, and the smoking molecules themselves go inside the cell. And once they go inside the cell, they induce cell death. So this is the most direct way to have the apoptosis of cell death in response to oxidative stress like smoking. So previously you was thought that all the smoking does is that it changes the lipid peroxidation of cell membrane and does a single transduction and then induces apoptosis. What we have shown is that that's not the case. If you combine the high resolution imaging with cell biology, you will come to different conclusion that these molecules themselves will depolarize membrane. And when we say depolarization of membrane, that's just like loading and having a lot of potassium in the media. In fact, one of the drug that is used for execution is the potassium. And what they do is that they depolarize the membrane of the heart so that heart will not even beat. So the heart stops beating. Okay, it's the same thing. So what means is that once you depolarize the membrane, the electrochemical gradient between the two sides of membrane is not there. So nothing can move in and out. So it's just a stop. There is no mechanical force generated. Okay. So this is the whole thing. So this is a smoking-induced emphysema. We are looking for cancer, but we didn't go that far. We are looking for emphysema. Okay. So this is now we have a group on working on extending the. Now we know that apoptosis is due to hemichannel-mediated transfer of smoking molecule inside the cell. Now we are looking at the whole signal transduction pathway. What are the gene activated, what are the protein involved, and so on and so on. This is in collaboration with Shankar Subramaniam. He started bioinformatics at UCSD, and he's my colleague. Actually, right now he's also chairman of my department for next 6 months. But this is in collaboration with this one, and Ramachandran is MD, PhD from here. He's one of my smartest, research assistant professor. So this is all we are looking at this part. So hopefully next 6 months of time, we will have the whole pathway defined for a smoking-induced apoptosis in response to hemichannel activity. Okay. Now I'm going to go to second work that I'm going to show is on amyloids and disease. And amyloid by definition is the protein structure dependent. So what means is that it's all misfolded protein. If the protein is misfolded or properly folded, they behave completely differently. So like sodium channel, potassium channel, or acetylcholine receptors, they're all properly folded proteins. If they misfold, they go from soluble to insoluble form, and they have completely different functions. In fact, in almost all the cases that we know, they form toxic, they have toxic properties. So that, so, if it's an ion channel, they're toxic ion channel. Okay, so they're also called conformational disorder. If you're a chemist, you call conformational disorder. If you are a biologist, you call it, if you're a doctor, you call amyloidosis, but it's the same name. Okay, so all of them have one thing in common, that if this is a hallmark of pathology that we see from brains. So this is for Alzheimer's disease, this is Parkinson's disease, Huntington, this is Lou Gehrig disease, this is prion, the simple mad count disease. Almost all of them have the same thing, that they all have fibers and they are plaques. Okay, what we have shown till we started working on that, in fact, till 5 years ago, almost every of these protein misfolding diseases were assumed to be because of the fiber made by these amyloid protein, and they induce toxicity by either inflammation or binding to cell surface receptors or inducing some signal transduction pathway. None of them work. So what we have done is that we have shown that we have defined a new paradigm using atomic force microscopy, fluorescence microscopy, electrophysiology, MD simulation, so and so, that almost all of these diseases, from Alzheimer's disease to arthritis and tuberculosis to diabetes to Parkinson, almost all of them, they are caused because these misfolded protein, they bind to the membrane and they make ion channel, and once they make ion channel, they change the ionic homeostasis. Means, for example, if they increase the calcium very high inside the cell becomes toxic, because outside calcium is almost 1,000 times more than inside the calcium inside the cell. But if you have a lot of calcium, that becomes toxic. So all of them is because of the ion channel. So that's the defining new paradigm. Okay, so now I'm going for biosensors. I think I have 15-20 minutes, is that right? Because I started late. So okay, so I'm going to go for nanobiosensors, and again I'm going to go and give you examples only on cantilever mechanics based approach. There are various other ways to do it, but our expertise is on mechanics, cantilever mechanics. So that I'm going to give you example of how fascinating it is and how much it can help you for diagnosis. Okay, so this is a single molecular spectroscopy of living cells. This is locating disease-specific membrane biomarkers. Means if you want to, suppose you want to go for diagnosis, and somebody takes the fluid, some fluid, body fluid from from you, and looks at what the biomarkers are there, what are the molecules there. Okay, or they can extend back, since these molecules are specific to some receptors or ion channels or something on the cell membrane, glycoprotein or sugar moiety or so and so. You have to know that. You have to map them. So what we did is that we use atomic force microscope. This is endothelial cell, live endothelial cells, and this is atomic force microscopy image. You can go literally up to few nanometer resolution, and we took the antibodies to the growth factor, which is involved in growth of endothelial cell. That's why I call growth factor. So antibody to growth factor is on AFM tape, and now I'm scanning the cell surface. Now there will be always antibody and receptor interactions. Every place where antibody interacts with receptor, there will be attraction. So the cantilever will deflect. So I'm basically mapping the force of interaction on the whole cell surface. So I can map the whole cell, and I can see where everywhere there is a hot spot, white one, you can see there are receptors and VEGF receptor. Now if I want to suppose I want to grow the cell. Cell will grow by two mechanisms. One is that these growth factors will cluster at the leading edge of the cell, and once they cluster, they will change the mechanical property of the cytoskeleton locally, so that it creates the force to move the cell back front. The reverse is in the back, so it goes back and forth, back and forth. So for the cell to grow or cell to die, the mechanical change in the cytoskeleton is very critical. So what we have done is that we put the antibody or ligand in this case and see what happens in real time. So you can see that hot spots are growing, means the receptors are clustering. And this is always at the leading edge, because cells are going this way and cells are going this way. Okay. Now what we did is that with atomic force microscopy, in addition to mapping and the clustering, we map the mechanical properties. And the idea is very simple, that if you apply if it's a soft tissue and apply, say, 1 Newton force, it will go down. If it's a hard tissue, 1 Newton force do nothing. So you're basically looking for a transfer function, that how much force you are putting in and how much you are getting out. Okay, and that will give you the incident, and give you the sense of the stiffness of the system, and that is done here. Okay, so this is a map of the stiffness. So this is so darker spot means stiffer. So what happens is that as the receptor cluster, there is local change in mechanical property. No. So using this technique, you can basically locate what are the biomarkers, structural biomarkers for particular disease. For example, in cancer, this will be completely different than non-cancer cells. So because we know that in cancer cell you have a lot of EGFR receptors. So if I want to diagnose, if I want to take the small cell, biopsy and look at the cells from cancer cell versus non-cancer cell, I can tell, well, there is a lot of EGFR receptor, means it's advanced stage versus not advanced stage. So that's the thing you can do, and this thing you can do literally in a 1 hour time if you have a good technician and good AFM. Okay, so then you can do same thing. You can use this one for high throughput, screening of biomarkers. What we have done here is that we have array of cantilevers, and basically, so what we want to started working on to do the allergen test. Like right now, if you go to doctor, you do allergy test. They do 1 allergen at a time, or maybe 4 or 5. So what we want to do is that we said, well, why don't we use the cantilever array? So we have 100 cantilevers, of 2 each, and each one of them has a specific antibody to say allergen 1, allergen 2, allergen 3, and 1 is just a control. So what happens that every time, and if I put a microfluidic chamber, flow chamber here, and and you can put the blood flow, for example. And there are array of these cantilevers, and each set of cantilevers have a specific antibody. So every time there is any allergen 1, 2, 3, 4, 5, this cantilever will deflect. And we know that that's a specific because it already has its inbuilt internal control. So you can look at those things, and you can sense the deflection of cantilever by various ways: fluorescence sensing, electrical sensing, mechanical sensing, and you can come back to whole thing to define, do the high throughput biomarkers. It can be anything for cancer to say heart disease to eye allergy and so and so. So everything is high throughput screening. Okay. Now you can do also is, as I mentioned, that you can look at the mechanics of the cell. And mechanical cells becomes very interesting because using the atomic force microscopy technique, you will be able to predict the mechanics at a nano scale. And this is what's shown here. So these are the heart cells, literally the pacemaker cells from heart, not from a human heart, but from rat heart. And this is, to show that you have myofibrils, that is muscle fibers, that it keeps the heart beating. And it's a beat frequency of this pacemaker is what defines our heartbeat. Okay. And then what we did is that we put the atomic force microscope tip right on top of this cell. And every time cell beats, there will be deflection will change, and you can measure the deflection. So if it beats 5 times a minute or 50 times a minute, your frequency will change, and the amplitude will also change. So this is the normal beating of these heart cells. Now, if you have tachycardia, for example, what happens is that heart start beating very fast, very, very, very fast. So that's the increase in frequency that you're seeing. But remember that the amplitude is low here. Okay, so amplitude remains same, not much difference, is the frequency changes. Now if you have tachycardia, you go to doctor, they'll give you negative inotrope drug which will reduce the beat frequency. Okay. Now when they do the measurement of this one, they don't, if the frequency is reduced, if the amplitude is reduced, there is no way you can measure it, because this amplitude, for example, here is a micron, for example. If the amplitude goes down to say 20-30 nanometers, you'll not be able to see it. So you go to doctor, they'll give you a drug, and say, fine, you are fine. Go back home. After 2 days, you are coming back again because it has not cured the disease, because they didn't have the sensitivity of technique to measure the amplitude and the frequency of beat. Okay, so that's where it comes into here, and you can use this one for diagnostics. Now you can say that, wait a minute, this is in vitro. It's not in the cell, in your body. And there are AFM being designed including my lab and other labs, which can be eventually translated back to inside the body. Okay, I'll give you one example of that one here. Okay, so this is for diagnostic purpose. Second one is correlating nano indentation and tissue elasticity. Okay, and this is for looking at mechanical strength and tissue stiffness based diagnostics. In fact, there are quite a few groups who are looking at cancer, muscular dystrophy, osteoporosis, all of them based on mechanics of the tissue. Okay, so this is, for example, this is a hair fiber. In fact, this is just the same hair fiber that we have. Okay, and what we wanted to do is that we want to look at, since the hair fiber or skin fiber, all of them have very high amount of keratin. So keratin is same everywhere. The concentration of keratin here is same as concentration of keratin here. But why one part is stiffer, other part is not stiffer? And that's what we want to do. So what we did is that we did a thin section, do electron microscopy, atomic force microscopy to just correlate that we're looking at the same structure, and then we use atomic force microscope to make indentation. So again, as I mentioned, that if it's softer, the same force will make a larger hole and wider hole. If it's a harder, it will make a smaller hole and not in a shallow hole. So you can see here, this is the outer part, this is the inner part, and this is somewhere here. Each one has different, indentation. So from here you can predict that this part is stronger than this part. And it's very interesting because what we did that, wait a minute, we said that everyone has same amount of keratin. Why one is harder, one is stronger? So what we did is that we did proteolytic treatment to see if you can break the disulfide bond in the keratin. Can you see the same stiffness everywhere? And that is shown here, that after using disulfide bond breakage with proteolytic enzyme, if you do nano indentation, almost it comes the same. So what it means is that the stiffness of or the strength of the fiber comes from the propensity of disulfide bond. And this is very interesting because if you take this tube, a tube here, you know that the strength of this one comes from the metal wire inside. It's not outside, it's just the protection from electrical shock and so and so. But in our case, in human body, for example, a skin, you think that the skin is softer, but it's not. It's very strong. In fact, you look at the mechanical prototype stream, skin, the outer layer is the strongest part. That's why when you want to do some drug delivery, dermally, it's very difficult to go in because it's very highly knit packed. Okay. Same thing in your, like if you're, I know that based on our work, L'Oreal has a whole lab on AFM to look at the structure of hair fiber based on all the cosmetics, because they want to every time you take the shampoo, you want to see whether your hair looks good or not, whether it's brittle or not, and those things. All of them is just based on this work. Okay. So this is correlative nano indentation and tissue elasticity. Now you extend back, up. This is actually brand new. It's not published by Paul Hansma's group. What he has done is that he has taken it one step further, and this is right inside your own patients, really osteoporosis patients, like who has a bone disease. So he's looking at, can you use atomic force based technique to predict with 99.9% accuracy whether you are going to have osteoporosis or not? And answer is yes. So what he did is that he has 2-chamber AFM. So this one just makes a very small hole, about 200-300 micron, that will never feel the pain. It's much smaller than even any needle that you have. And then you are just hitting with this probe inside and looking at the stiffness of the bone material. And he can predict with almost 99% accuracy that this is the bone of the fracture and this is non-fracture bone. So this is actually, this tool is in clinical trial in 8 countries right now, and so basically with a small tool, if you are going to a doctor, he can predict whether you are going to have bone disease, osteoporosis or not, with 99.9% accuracy. Right now his accuracy is about 90%. Okay, so that's a major step forward, and this is all based on cantilever mechanics based diagnostics. Okay. Now I'm going for in vivo sensors. I'm going to give you some examples of 3 sensors that we are looking for. Sensor for heart tissue relaxation and injury, sensor for lung and heart edema, and sensor for stent industrialization. All of them have a specific purpose. And this all started when I was at the University of Chicago, and I have a cardiovascular surgeon, Raman, and cardiologist near Jolly, and they said, well, every time they do any surgery, cardiovascular surgery, the first time patient comes back to clinic is because of edema. And by the time they come back, they have, they are already too late. So they wanted us to design sensors that when they do surgery, they can insert the edema sensor and tell us that whether you have edema or not. Because if you can control edema, you have better chance of survival. Like if you have brain edema, if you're not going to doctor in the right time, you'll be basically dead anyway. So what we did is that we use the cantilever-based design the cantilever-based sensors. Okay. So all of the devices and sensors that we are using are three things in common. One, they are nanoscale sensors placed in tissue safely, with long-term with no risk of reaction. That's the plan. That's the prospect, future. Okay, it's not there. The remotely actuatable sensors that can perform wireless operation, and it's a complex interplay of everybody from doctor to physicist to biochemist and and material scientist. So edema sensor is, that as I mentioned that edema or fluid buildup is a common manifestation of inflammation. Edema in the lung and periphery after heart failure is the most common cause of hospital admissions. Okay, and edema sensors that we are designing are an array of nanoscale implantable devices that can be put in a variety of tissue to monitor buildup of fluid. So this is just to show you 6 different sensors. All of them have cantilevers. Okay, so but this is temperature sensor, this is electrical resistance sensor, this is acoustic sensor, this is flow and volume sensors, and these are biological chemical sensors. Each one of are differently designed, but I'm not going to go in detail. I have to give the whole seminar, the whole thing on this itself. Okay, so then the second part is the stent. Like if anybody has a stent, you know that you are going to take Plavix or some drug for almost life. Because the reason is very simple, that once you have a stent, unless the stent is covered with endothelial cell, you always have reaction and that side effects and those things. So you want to take the drug so that there is no plaque formation till the endothelial cell is covered, covering the stent. So what we want to do is that we want to make a sensor on the stent itself that will allow us to tell whether the stent is covered with endothelial cells or not. And as you figure out, you must have figured out by this time that what we are doing is that we are putting these sensors here, and as the endothelial cells grow, there will be deflection, cantilever will deflect, and every time cantilever deflects, I'll get a signal through remote control, and that's all we are doing here. Okay, so that's the part of the in vivo diagnostics part. This promises right now is not there, but components are there. Now I'm going to go for drug delivery, and this is the last part of my talk, which will be 5-6 minutes that I'm going to talk about. This is nano carriers for targeted delivery of diagnostics and therapeutics. Very simple. Like suppose you do PET scanning or CAT scanning or MRI. By the time they show that you have cancer, it's already too late, because the signal to noise ratio for those imaging modality is very weak or very low. So unless the tumor is, say, in millimeter size, you'll not be able to diagnose it with PET scanning MRI. So there is there is a reason to have nanoscale system where you can inject high signal to noise ratio imaging modality. At the same time, you want to inject some drugs. And suppose, for example, it's a blood-brain barrier. Anything you want to get in the brain, you can do it right now. So that's the part that we are trying to do here. So it's a nanoparticle and nanostructure-based drug targeting and delivery. Okay, they could contain target guidance molecules and transport drugs within or bound to their surface. There are various ways to come to. I'll come to that part. So the various ways to do drug delivery that is everybody is leading to are nanotubes, nanoclusters, nanocells, liposomes, dendrimers, and all of these things, nanoballs, nanoweapons, magnetic vectors. We work mostly on these ones. I'll come to why. And we got on liposomes. Actually, liposome-based drug delivery is FDA approved. That's the only one is available right now. The first most important area was nanotube based. But I think nanotube is so toxic nowadays that anything based on nanotube is not going to be approved at FDA, for example, unless you want to kill the cell. If your aim is to kill locally some cells, cancer cells, for example, you can use the nanotube, otherwise it's not going to go. But these are the things that you're going to use it. So a specific consideration that we put in our lab and should be put in anywhere are: one, biocompatibility. Are these vehicle biocompatible? Two, they are in vivo stable, they are non-toxic, they are recyclable, and they are cheap. If they are not cheap, they will not be able to, nobody will be able to buy it. Okay. So what we have done is that we are trying to design DNA-gated drug delivery systems. So I have a physicist who is a collateral physicist, PhD, and what he's doing is that, if you remember ATGC in the DNA 2S strands, and AT and and GC and IC. So IC bond, IC is weaker bond than GC bond. So what we are doing is that we are removing I to C, I to G, and so, and making one end weaker. So what it means is that if the normal complement of this one comes here, G, ATGC, it binds here. Now what happens is that this part will come out. So it comes out. So what it means is that I can design a zipper, or I can design a gate which can be open or closed based on how many ICGC bonds we have. And based on ICGC bond, I can predict the force of opening and closing. So we have designed the system to have a zipper or motor which will give up to 9.7 piconewton force. Okay, 9.7 piconewton force for one motor, and you can add it in series. You can create up to 150 piconewton force. That force is sufficient to move something. So if you are looking at nanorobotics or something, you can use that one to move it. Or if you have our aim is for drug delivery, so you have a ball here, and we put the gate here, and you can open and close the gate based on pH and temperature sensitive. In fact, we have made this one such that we can open or close, or you can move the gate by 2 degrees centigrade temperature difference. So imagine if I want to make a capsule which has a lot of drugs inside. They are nano capsules, and all of them have the gate on top, and this gate is closed at room temperature. Now insert in the body, and if you have inflammation or if you have immune response, your body temperature hits up to 38 degrees centigrade, it can open it. You can locally open it, you can close it, and so on. So it's all repeatable. So this is what is done here. So this is just to show you the cartoon. This is a graduate student in collaboration with cancer group, and what we are looking for is that we have biodegradable polymers, and here, and you have targeting molecules, and you have drug molecules. All of them goes into, and this is the gate that we are talking about. So this is not the cartoon. This is actually made in our lab so far. So this gate can open and close as a function of temperature or pH, and I can remotely actuate also. Like suppose I put a small magnetic particle, and I can do, or iron particle, I can do infrared light, shine it, I can heat it up, and I can release it. So this is all temperature pH sensitive. And this is just to show the cartoon for targeted drug delivery. Again, this is targeted delivery. Okay, means but it's not very uniform. Like for example, if I'm putting a drug in here, in my hand here, and I want to pass it on all the way to the brain or to liver where the cancer I have, suppose I have cancer, I want to put it there. Can I do it here? Because if you put the drug inside, you have no control. It goes anywhere systemically, and it can just go by anywhere. So what we did is that we used that targeting molecule. In this case, this is so-called GAMO's paradigm of remotely guided in vivo sensor, like nanorobots. That what we have designed is that we have a small capsule with a small magnetic particle inside. Now since there is a magnetic particle inside, I can put a small magnet on both sides, and by changing the magnetic field, I can force it to go everywhere I want. And that's what we have been able to achieve. This is already published in Nano Letter. The next one I'm going to show you. So what we did is that we use a magnetically vectored nano capsule. The super paramagnetic particle, which is about 10 nanometer in diameter size. Okay, and they are and it's a magnetically it's sensitive to magnetic field. Okay, I'm not going to go into detail here because that's a physics seminar. So what we would have is that we have magnetic particle and we have drug inside, and so it's all mixed in here. Okay. Now I can take it here in a small magnetic field, and the question is, how can I release the drug out of it? So the answer is very simple. If you put a small, if it's a regular magnetic field, DC magnetic field, you can guide it to anywhere you want. If you have a radio frequency magnetic field, it will heat up the molecule. Once it heats it up, the pores will be larger, and you can release the drug. And you can do on and off. In fact, this is the radio frequency for heating, and this is low frequency for targeting. And you can release the drug as truly as a function of the magnetic field. And this is on and off, means I can release it and you can close it, I can release it, I can close it, so and so. And that's shown in here. So basically the radio frequency magnetic field is on, it's open, and it's off, it's closed, and so you can do a whole thing in real series. So what it means is that you have a system that you can target to anywhere you want, and then you can open and close it as you want. Okay, so that's the nano later paper, and this is the two-step, because this is, say this is a cancer tissue, we can release the drug by simply putting a magnetic field here, and everything will go through here. And once it's here, make it radio frequency, and you can release the drug, and that is shown here. So this is actual data from the rat. Okay, and this is Michael Kerin. He was one of the big. He's one of our colleague, and he does all the things on cancer. So this is the tail vein injection of this magnetic particle with drug. In this case, I think it's captopril. I'm not a doctor, so you have to think. You have to give me some credit for not pronouncing name correctly. But point here is that these are all fluorescent levels. So if there is a magnetic field, you can direct it anywhere you want. If there is no magnetic field, it goes nowhere. Okay? So this is the magnet, and this is inside the cancer in the liver. Okay? And if you turn the radio frequency off, this is the cell growth is reduced with radio frequency, without radio frequency, and you can basically kill the cell, cancer. So this is for cancer. What we have shown is that the toxicity is not there. So that data I'm not going to show you here. So this is for anywhere in the body. Now our aim is that, can I do this one for blood-brain barrier? And answer is yes. These are just two more slides here. So this is blood-brain barrier crossing. Same paradigm. We are putting a small magnet right here on the top, on the rat. And we are injecting the whole vectored capsule inside in the tail. And the magnetic field will allow you to hear, and you apply a little bit larger magnetic field, and that will cross the blood-brain barrier. And this is just to show that these small molecules with nanovectors are already crossing. So this is a part of this whole thing, and they are not toxic. We don't know how they are coming out of the brain, but they are coming out. This is where one of the authors is Veronica Sowev. She's MD, and she does all the animal model. Assumption is that we're going to extend it to the sometime in animal human model system, maybe next 5 years or so, if it works and it's not toxic. I think I'm going to stop here. So what I've shown you is that accelerating nanotechnology application to human disease, or you need three parts of it. It's nanoscience and nanotechnology that I define or give you example. You have to have nanobiotechnology, and you have to have resources and expertise. And resources and expertise, I think India can afford now. Maybe 20 years ago or 30 years ago when I left, it was not possible. So you do have the resources and expertise. All you need is real enthusiasm and good graduate students to take you forward. I think I'm going to stop here.